The argument here is that the disease we're talking about is cutaneous squamous cell cancer. And cutaneous squamous cell cancer most commonly begins in the head and neck. Now, I find that head and neck surgeons are often involved in its surgical treatment, and head and neck surgeons more frequently treat mucosal squamous cell head and neck cancers. And since I'm a head and neck medical oncologist, I also treat mucosal squamous cell cancers, ergo, I'm the most likely person to talk about cutaneous squamous cell cancer. Now, I don't know if this logic is correct or not, but that's where we are, and it's actually, I think, my biggest challenge in this disease. Unfortunately, there are very few, if any, medical oncologists who really have a dedicated interest in cutaneous squamous cell cancer. I think most of us treat this disease kind of as a side gig. It's not our primary interest. And when we do treat these patients, we have very little evidence to use in our treatment decisions. Instead, what we do is we just extrapolate from our experience treating mucosal disease. And whether that's accurate or not, I don't know, because I think, as we're all aware, these diseases are very different. The patients are different. The etiology of the disease is different. The comorbidities are different. Natural history is very different. So whether this assumption is correct, I think, is subject to some question. The national practice guidelines that we have for squamous cell cutaneous cancers really reflect the fact that there's very limited evidence on which to base any recommendations, and they've been very non-committal. National Comprehensive Cancer Network, for example, and in most recent guidelines, talk about regionally advanced disease and state that multidisciplinary consultation is recommended. Consider systemic therapies recommended for use with radiation to treat head and neck mucosal squamous cell cancers, and then they refer you to the head and neck cancer guidelines. For patients with distant metastases, they state that the development of distant metastases should be managed by a multidisciplinary tumor board. Cisplatin and EGFR inhibitors have each occasionally produced useful responses, but data supporting efficacy are limited, and the NCCN panel encourages participation in a clinical trial. That's really just their way of saying, we don't know what to tell you what to do. Shlomo Koifman at our institution chaired the American College of Radiology Appropriateness panel that looked at the way to manage non-melanoma skin cancer in the head and neck and talked about cutaneous squamous cell cancers, stating that there really are no randomized studies confirming the added utility of concurrent systemic chemotherapy in conjunction with radiation, either in the definitive or adjuvant setting. Concurrent cisplatin-based chemotherapy can be considered by extrapolation of practices from head and neck mucosal squamous cell cancer. Again, no definitive data about cutaneous squamous cell cancers. So I'm going to spend a couple of minutes just looking at what we might be able to extrapolate from studies in mucosal disease, and in particular, can we identify a role for chemotherapy in patients at high risk for disease recurrence after surgical resection? So let's look at the head and neck mucosal data. There are two studies that have been done that have become landmark studies for us in the head and neck world. These are two trials that looked at the role of adjuvant chemotherapy and radiation in patients with high-risk mucosal disease after surgery. And both of these studies were done at the same time, one in North America and one in Europe. Patients after surgery with high-risk features would be randomized either to radiation alone postoperatively or radiation and concurrent high-dose cisplatin. This is a pretty toxic treatment regimen. It's been around for now 30 years, and it's quite difficult for patients to get through. Now, the studies were designed the same. The eligibility criteria were different. I think it's important just to point this out. When you're looking at trying to improve the outcomes after surgery, you need to identify a high-risk population to see which population is most likely to benefit from your intervention. So the two studies were somewhat different. The European study had these risk factors. The North American study had these risk factors. They overlapped in terms of surgical margins and extracapsular nodal extension. The studies were so similar in design, however, that the results were pooled. And we look at various outcomes here, local control, disease-free survival, or overall survival. and we look at whether the patients benefited from the chemotherapy and radiation or did not, we see that both the individual studies and the combined studies suggested that the chemotherapy and radiation together improved local control, improved disease-free survival, and improved overall survival, at least in the pooled analysis. But then the pooled analysis went one step further and looked at eligibility criteria and looked at those patients who met the eligibility criteria for both trials, who had positive surgical margins and or extracapsular nodal extension, and saw that the benefit was essentially limited to those patients. They couldn't really detect a significant benefit in patients who did not have those high-risk features. And even though this is a retrospective and an unplanned subgroup analysis, this has really led to the standard of care recommendations in mucosal head and neck cancer, that those patients after surgery who have extracapsular nodal extension or who have surgical margins that are positive should get postoperative chemotherapy and radiation. All right, so why is that important in cutaneous squamous cell cancer? Well, this is a study that was presented at our national meeting last year and actually just came out in the Journal of Clinical Oncology today. This was a high-level evidence trial that was done from Australia and New Zealand, the Trans-Tasman Radiation Oncology Group, looking at the role of concurrent chemotherapy and radiation versus radiation alone in patients at high risk with cutaneous squamous cell cancer after surgery. The objective was to see if adding the chemotherapy made any difference. The study design looked like this. Patients with cutaneous squamous cell cancer would undergo curative intent surgery. Stratification was based on whether they had advanced primary site disease or high-risk nodal disease, and then they were randomized between radiation alone or radiation and concurrent chemotherapy. I would point this out. The chemotherapy was weekly carboplatin for 6 doses. I made the point that the cisplatin regimen used in mucosal disease is quite difficult to tolerate. Weekly carboplatin is pretty wimpy chemotherapy from our point of view. This is very easy to tolerate, and I'll show you some of their results. Now, the inclusion criteria are interesting. Obviously, histologically proven disease, high-risk features, good performance status, and macroscopic gross resection. I think what's most important is that the immunosuppressed patients were excluded. I think it's important because these are the patients at highest risk for disease recurrence. These are the patients for whom adjuvant therapy of some sort would most likely be of benefit. And this is actually data from Cleveland Clinic and 2 other institutions looking at our results in patients who undergo surgery and postoperative radiation, pointing out again that those patients who are immunosuppressed have outcomes that are dramatically worse than those patients who do not. And so if you're going to target adjuvant interventions, target some treatment to try and improve the outcomes, one would think you'd want to target these patients more than these patients. Their outcomes are twice as good. So getting back to the study design, looking at what were the definitions of advanced primary site disease or high-risk nodal disease. We see advanced primaries were people with T3 to 4 disease, early nodal disease and T3 to 4 disease, in-transit metastases, extracapsular nodal extension, intraparotid metastases, multiple cervical nodes or large cervical nodes. Let me just point out that the only patients who would receive adjuvant chemotherapy and radiation if this was mucosal disease would be these patients. So this is a much broader group of patients with risk factors that, at least for mucosal head and neck cancer, would be less impressive and would not demand the use of concurrent chemotherapy. Just from the point of view of patient and tumor characteristics, I would point out that this is a group of patients that was surprisingly young for cutaneous squamous cell cancer, median age 63 years, predominantly male. Most patients were entered because of high-risk nodal disease. Patients were treated and got very good. The treatment was delivered very well. Most patients got the full dose of radiation. 84% got all of their chemotherapy. And the chemotherapy was indeed pretty wimpy. Of the 148 patients for whom there was data about the chemotherapy, only 5% had grade 3 or greater adverse events. For medical oncologists, this is nothing. We generally see adverse events in the 30, 40, 50, 60% range, greater than grade 3, and clearly represents very well tolerated chemotherapy or suboptimal chemotherapy, depending on which way you're looking at it. These are the results. Absolutely no benefit from the chemotherapy. This is the highest level evidence we have about the role of adjuvant cytotoxic chemotherapy in the adjuvant treatment of cutaneous squamous cell cancer. Absolutely no benefit. But let me point out how well the patients who got radiation alone did. They did very, very well. It would be very hard to demonstrate a benefit when you're looking at 5-month survivals and recurrence-free survivals that are close to 90%. So the conclusions from the study were that the outcomes are excellent after surgery and postoperative radiation in patients with high-risk cutaneous squamous cell disease. The addition of concurrent carboplatin chemotherapy did not add greatly to treatment toxicity, and the addition of concurrent carboplatin chemotherapy did not improve outcomes. I think I would make the point that high-risk disease needs to be better defined if you're going to identify any improvement, and you need better chemotherapy than weekly carboplatin. This was probably not the best choice of drug. The authors acknowledge this. They state that they chose this chemotherapy regimen in large part because they were concerned about the frailty of the patient population. I think that the patients who were chosen ultimately didn't prove to be terribly frail and actually did very well with the treatment. Nonetheless, unlike mucosal squamous cell cancers, the addition of chemotherapy to postoperative radiation is certainly not a treatment standard for high-risk cutaneous squamous cell cancer. I'm not sure that the ballgame is over. I think that there is certainly still a suggestion out there that there may be a benefit if we use the right drug or we pick the right patient population, and I would just call your attention to this report from Moffitt Cancer Center in Florida. This was a retrospective cohort study over 13 years, 61 high-risk postoperative patients with stage 3 or 4 disease, and their high-risk features were much higher risk. They had more than 2 regional nodes involved, positive margins or extracapsular nodal extension. Patients were, again, looked at retrospectively, but they were either treated with radiation alone or concurrent platinum-based chemotherapy and radiation. In this series, it was noted that those patients in the chemoradiation group, not surprisingly, were worse patients. They had larger T's, greater N's, and more poorly differentiated tumors. And then the outcomes were retrospectively compared. At least this data is a little bit more suggestive. If we look here at recurrence-free survival, we do see that there was a benefit seen in the chemoradiation patients. But again, this is retrospective data, and we have to take it with a grain of salt. But I guess I would point out the survival of the control group here, the recurrence-free survival of the control group, and the overall survival of the control group compared to the Australian study. You see the very different patient populations. Okay, changing gears a little bit, what about recurrent or metastatic disease? Is there a role for systemic therapy in patients with advanced cutaneous squamous cell cancer, not amenable to radiation or surgery? There are no randomized trials. The evidence that is out there consists of case reports, it consists of small retrospective series, and there are very rare phase 2 trials. The evidence out there just doesn't exist. Cytotoxic agents have been used all over the map. We've drawn our experience again from the mucosal disease using cisplatin, fluorouracil, doxorubicin, bleomycin, vindicin, et cetera. The response rates seen are modest, the responses are transient, and toxicity remains a major concern given the demographics of the patient population. There is a little bit more organized experience using the EGFR, the epidermal growth factor receptor inhibitors, drugs like cetuximab, which is a monoclonal antibody, or the TKI inhibitors like gefitinib, erlotinib, and lapatinib. And there have been a number of anecdotal reports, really, of concurrent and sequential approaches. The results are a little bit more encouraging. This is probably the best study out there using single-agent cetuximab in patients with advanced cutaneous disease. It's a prospective trial of only 36 patients, so this is the best evidence out there. The best response, complete response in 6%, partial response in 22%, and then something we euphemistically call disease control rate, meaning complete response, partial response, and stable disease, measured at 6 weeks, which is almost nothing. And that's reported at 69%, and this number looks more robust, so we tend to report disease control rates. Grade 3 to 4 toxicity, 61%, much more what we're used to seeing in medical oncology. And these are the survival curves. This is just patients investigator assessed and patients assessed by the outside investigating team. And you see here that the overall survival is measured in months here rather than years. It's interesting. It's the best evidence out there. It's not terribly exciting. This is, as we've already heard this morning, the checkpoint inhibitors are assuming a larger and larger role in medical oncology in general and are finding their place in the management of skin cancers. Most of the major companies are jockeying about trying to find niches for their particular drug. Nobody has paid a lot of attention to cutaneous squamous cell cancer. A small company called Regeneron, however, has jumped in here and last year reported results at our national meeting. Now what they did was did a very large phase 1, meaning toxicity trial of their anti-PD-1 monoclonal antibody in a whole host of different tumors. And they found that in some of the tumors that were treated, there was promising evidence of response. And one of those tumors was cutaneous squamous cell cancer. So the company created an expansion cohort. There were 2 expansion cohorts for skin cancer, one in metastatic disease and one in locally or regionally advanced disease. And patients were treated with this Regeneron agent, Regeneron 2810, looking both at the toxicity, the tolerability of the agent, and looking preliminarily at response. And this was reported last year. Notice the exclusion criteria. These companies are very careful about the kind of patients that are being treated. Nobody with autoimmune disease, nobody here who was a solid organ transplant. They're looking at patients where they're likely not to run into difficulties. Patient characteristics here, older patient population, mostly male, and mostly head and neck origin. I would point out that these drugs, this whole class of drugs, infinitely better tolerated in general than the cytotoxic agents, even better tolerated than a drug like cetuximab. We see here that the grade 3 or greater adverse events, very infrequent. A couple of patients had to stop, an 86-year-old and an 88-year-old. There were a couple of deaths not attributed to the drug. Very well tolerated agents. And these are the response rates. Complete response and partial responses of 46%, disease control rate of 69%. If we use this class of agents in patients with mucosal head and neck cancer, we see response rates of 15 to 20%. We see disease control rates of about 30%. So there's something very different about cutaneous squamous cell cancer than there is about mucosal squamous cell cancer. And these are truly unheard of response rates in this disease. We like to show these responses on these things called waterfall plots. These really exaggerate the benefit of any of our agents. You see any of these downgoing bars represent a patient whose measurable tumor shrank. Actually, we use this 30% cutoff as something to define response, but still, this looks very impressive. Looks like almost all the patients responded. I think the important point about this drug is right here. Of the patients who responded, 10 remain in response more than between 8 and 40 weeks after after initiation of therapy. This is what we tend to characterize as the deep and durable responses. Patients who respond seem to remain in response for a long period of time. We don't know how long yet, but that's what's most impressive about these drugs. So the company rapidly developed what they call a pivotal phase 2 trial. Pivotal is actually just a political statement trying to tell us that this is what we're going to need to do. But they developed this phase 2 trial, again, looking at the patients with metastatic disease and patients with locally advanced disease, using the Regeneron agent in 2 different dosing schedules, and looking at significant numbers of patients now, not just teens and 20s, but large numbers of patients. And this study began enrolling last year. We've participated in it. The results are available, but notice, the results came out in a press release. This has not come out in the scientific literature. It hasn't been presented at a national meeting. It came out in a press release in December. We will hear these results at our meeting next month. The drug, now called cemiplimab, produced an overall response rate of 46% in the first 82 of a planned 182 patients enrolled on the study. So not only did it come out as a press release, it came out with incomplete data. But this data was clearly submitted to the FDA. With a minimum follow-up of 6 months, 32 of the 38 responses are ongoing, and the median duration of response has not been reached. And this is the important point here. This is what's most interesting. There have been no new safety signals, and the FDA review is underway. We anticipate that this drug is going to be approved for use in the very near future. So the conclusions from this approach are that this agent, like the other PD-1 inhibitors, is well tolerated, even in elderly patients. Both locally advanced and metastatic cutaneous squamous cell cancer are highly responsive to this agent, and these responses may prove durable. Now, I don't know what durable means. I don't think that that necessarily means curable, but certainly the responses can be of long duration. I think we expect this responsiveness with the other PD-1 inhibitors. We all have anecdotal experience using drugs like pembrolizumab and nivolumab, which are also very active. And we're going to hear much more about this soon, but the Regeneron folks have gotten in first. Further study of these agents for cutaneous squamous cell cancer in other settings, for example, in the postoperative setting, is very reasonable. And this is a study which we currently have up and running at the Cleveland Clinic looking at this question. It's a phase 2 study of postoperative radiation and concurrent pembrolizumab for patients with high-risk disease. We've defined high-risk disease here as a little more broadly than perhaps we should. T4 disease, node positivity, or earlier T disease with additional risk factors, and patients are given radiation and concurrent pembro for a total of 6 doses. This study is up and running. If you have patients you'd like to send our way, we'd be interested in treating them. So if I can conclude about the overall medical treatment of cutaneous squamous cell cancers, although we can learn from our experience treating mucosal disease, cutaneous squamous cell cancer is an entirely different disease. The patient population is different. Conventional cytotoxic chemotherapy is not a proven benefit in either the high-risk adjuvant setting or in the metastatic setting. The potential benefit of the EGFR inhibitors has really not been well investigated. This does, however, appear to be a disease that's more responsive to checkpoint inhibition than mucosal cancers, and these agents appear to have considerable promise for the immediate future. And unfortunately, at the present time, the treatment of advanced cutaneous squamous cell cancer in the immunosuppressed population remains problematic and unexplored.